Start my presentation.
Yeah. Have you ever
my-
given anesthesia for a cleft lip or palate?
No, sir.
Oh. So you are going to present from the book, not from practice. Okay. Okay, go ahead.
It is a case of a 3-month-old female child, baby of Janagi, residing at Kolathur. The informant is mother and with a good reliable history. Presented the chief complaint of opening in the left upper lip since birth and poor feeding since birth. History of presenting illness. The mother complains of a deformity in the left upper lip since birth, with history of difficulty in breastfeeding since birth. There is history of regurgitation and recurrent nasal discharge in the baby since birth, usually including the recent feed. There is no history of fever, cough, breathing difficulty, snoring, or nasal stuffiness at present. There is history of ear discharge on and off for this patient. There is no history of loss of breath during feeds or apnea during feeds. And currently the child is fed with Palate with expressed breast milk for the past 2 months. Coming to past history, there is history of recurrent ear infections and nasal discharge and upper respiratory tract infection since birth, and the last episode of ear infections 2 weeks back. There is no history of any anesthesia or past surgical exposure in the baby. Coming to maternal history, this is the first child born out of non-consanguineous marriage, and it is a spontaneous conception, and there is no history of any drug intake, radiation exposure, or infection during antenatal period, and there is no use of alcohol or smoking in the mother. Coming to birth history, it is a term baby delivered by normal vaginal delivery, and the child cried at birth, and the birth weight is 3 kg. There is no history of any ICU admission for the child. The child is immunized and attained developmental milestones as per the age. And coming to family history, there is no history of congenital anomalies or similar presentations in the family. Coming to the summary, it is a 3-month-old female child which presents with left side upper lip deformity, and with the recurrent history of recurrent ear infection and history of recurrent upper respiratory tract infections.
Okay. So this is a case scenario which you have formed yourself, or did you get any case to examine and then present here?
Formed myself.
Your own formation. Okay. Because it is very obvious that recurrent ear infections within 3 months of birth is very, very uncommon. Okay. And you should not say poor feeding, you should say difficulty in feeding. Okay. So because of the defect in the left side of the upper lip, you can't say left up lip and the right lip. There is only one lip, upper lip and lower lip. And left side of the upper lip and right side of the upper lip. That is how you have to describe. Okay. So you have to correct these 3 mistakes in the presentation. Okay. Right, go ahead.
Coming to general examination, the child is alert and active. Height is 61 centimeter, weight is 6 kg, both falling under 15th percentile according to WHO growth chart. The child is safe with bed, has no icterus, cyanosis, clubbing, generalized lymphadenopathy, pedal edema. Heart rate is 120 per minute, regular and good volume. Respiratory rate is 30 per minute, and the room air saturation is 99%. Coming to airway examination, there is a left side, in the upper lip, left side, there is a cleft lip involving completely both, so from the nostrils till the alveolar end. and a cleft palate involving hard palate on the left side, with no defect in the soft palate and uvula. Facial features, there is no features of micronatria, retronatria, low set ears, or macroglossia, or flat nose, or webbed neck. Systemic examination, respiratory system, pilot on a visual examination, there is no chest deformity. On a bilateral chest expansion was normal. Trachea seems to be in midline, and palpation same. Bilateral chest expansion was normal, and the trachea was in midline. On auscultation, bilateral non-vesicular breath sounds were heard, and no added sounds were seen. Coming to cardiovascular system examination, apex beat was felt in the left 50 intercostal space, lateral to midclavicular line. S1, S2 heard, no murmurs. Abdomen was soft, non-tender, and no organomegaly. Central nervous system examination, no signs of focal neurological deficits.
Okay, you have completed?
Yes.
Okay. So this is usually kept as a short case in your examination. Okay.
Yes.
So what is your provisional diagnosis when it is kept like this? They just try one question they ask you is, what is your diagnosis? Like a spotter, you have to tell the diagnosis. What is your final diagnosis about this case?
After examination, this is a left-sided complete cleft lip with incomplete cleft palate.
Incomplete. How do you say it is incomplete cleft palate?
Doesn't involve with the actual visualization directly spotter. We cannot say, sir. We have to ask the child to open.
Yeah, whatever you can examine. See, spotter means it is not that you look at the face from outside only. If you want to open the mouth and make the mother open the mouth, you can as well ask all these things and then make a diagnosis. So there are two conditions. One is a complete isolated cleft lip or incomplete cleft lip is there. So how do you classify these clefts in the face?
It is either as complete or incomplete.
Unilateral or bilateral first?
Bilateral.
Okay. Now is this a unilateral cleft or a bilateral cleft?
It's a unilateral cleft.
Unilateral cleft. Okay. Then the next description you have to give is whether it is complete or incomplete. Now you say it is a complete cleft of the lip with incomplete cleft of the palate. How do you say that it is incomplete cleft of the palate?
Didn't involve the soft palate.
So only if it involves the soft palate also, supposing there is only a soft palate defect, what will you call it?
Isolated cleft palate.
Huh?
Unilateral isolated cleft palate.
Unilateral isolated cleft palate, incomplete cleft palate. Okay. So which portion of the hard palate did you find it defective? That's the gap. The alveolus
primary
involves the primary palate also.
Yes, sir.
See, which are all the portions of the face there is a gap or a cleft? You say lip is there is a cleft. Does it go up to the nostril sill?
Lip has extension up to nostril, sir.
Nostril, okay.
Yes.
Is the ala of the nostril attached to other side or it is away from the other side?
Away from the other side.
Away from the other side. Are you able to see the tongue through the nostril opening?
Yes, sir.
Yes. So that means it is a complete cleft of the lip. So are you able to see any continuity in the alveolar bone?
No, sir.
So there is a defect there also. Okay. How far that defect in the alveolar bone extends inside the mouth?
About midway.
About a centimeter or so. Okay.
Yes.
The rest of the hard palate, is it intact?
Intact.
Intact. Is the soft palate intact?
Intact.
Then It is an isolated cleft lip only, complete cleft of the lip only. Okay. So in the complete cleft of the lip, the entire lip on the left side will be defective up to the nostril sill, and the ala will be away. There will be a defect in the alveolus underneath the cleft, and that defect will also extend up to the some portion of the hard palate, which is called the primary palate. Okay. So how do you anatomically divide the primary and secondary palates? What is the landmark?
That is incisura foramen.
Incisive foramen. Very good.
Incisive.
Okay. So in whatever is present in front of the incisive foramen is called the primary palate, and whatever is behind the incisive foramen is called the secondary palate. So in the complete cleft of the lip, the portion of the palate, including the primary palate, will also be involved. Okay, there will be a gap in the hard palate along with the alveolar bone, and it will also involve the soft tissue of the one side of the lip up to the nostril sill. Through the gap, you can always see some portion of the tongue also. Okay, so that is what is called the complete cleft of the. Which one will you say as incomplete? Which lip you will describe as incomplete?
Incomplete cleft lip you are asking, sir, or palate?
Incomplete cleft lip. Now we have decided that the diagnosis is only a complete cleft of the lip. There is no involvement of the palate.
Palate, sir.
So in this case, I am really wondering how regurgitation through the nose can happen, because it is much more anterior. The cleft is much more anterior. Unless even the hard palate also you find that defect, and it goes up to the soft palate to make the uvula into two halves, what is called the bifidula. Then only it can be called as a complete cleft of the palate and the lip on the left side. Okay. When I show you the presentation, you will be able to appreciate each difference between all these various conditions. Unless you have seen such cases or anesthetized such cases, it's very difficult to imagine and present how you. Anybody else in the crowd who have anesthetized these cases have any experience? Pratik Shukla?
Sir, I haven't anesthetized, sir. I haven't seen also.
You have not also seen.
Sir, he's not mentioned. He's not answered your question, sir. Incomplete cleft lip.
No, I will come to that later. I am trying to find out in the audience whether anyone has the experience. Dr. Preeti Shukla, Bombay. Are you there, Dr. Preeti Shukla? Or Pavitra from Annamalai?
We have done, sir.
You have done? Okay.
Yes, sir.
Who is this? Dr. Nandini Devendran? Where are you from?
These are theatre matron, sir, from Arch Perambur.
Oh, cleft matron.
Nice. Okay.
Okay. And who is Akash Yadav?
Bombay, sir. He's from Bombay. Dr. Akash Yadav, you can introduce yourself. He presented, sir, once.
Okay.
Okay.
Yeah. I remember. Have you had any opportunity to anesthetize a cleft lip and palate? Akash ji, आप उधर हैं? नहीं. Okay, right. We'll go ahead. So, what is incomplete cleft of the lip?
When the cleft doesn't reach up to the nostrils.
So I think Kamachi, this sort of cases should have been given to somebody who has had at least done one or two cases like this, rather than putting them under stress by asking them to imagine.
Yes, it's very difficult to imagine.
Very difficult. Yeah.
Yeah.
This is not
Yes,
an
sir.
easy anesthesia. No, it requires a lot of skill because most of them are children. Especially lip, you have to do under 2-3 months. Can Dr. Pavitra, who has anesthetized, can you take over and present instead of troubling Mubin, who is doing everything from his imagination? Dr. Pavitra, are you there?
sir, but I haven't prepared anything, sir.
No, not necessary. You have done, when you have done a case, you can easily answer all the questions, isn't it? Every class, if you want to prepare, then in the examination, you will be only preparing. This is like a extempo viva. You have to start how many cases have you anesthetized? Or just describe the case you have done, how you did, how you prepared the case, how you anesthetized, what surgery was done on the baby, what was the age of the
Okay, sir.
child. You have your logbook with you?
Yes, sir.
So can you just go through that and find out which date you did and what type of case you did, even if you can't recall? Because only doing the cases you will remember how to manage, what complications happened, what difficulties you underwent. All these things we can find out only by practical management of a case, isn't it?
Okay. Yes, sir.
Pavitra, tell me what case you did. Lip
Sir, we
surgery or
have done
palate
for
surgery? Uh,
sir, we have done for lip only, sir.
Ah.
Both lip and palate involved, sir.
uh,
First, they operated for lip, sir.
Lip only was corrected. Okay. What was the age of the child? Is it an adult or
3 months.
3 months
3
old?
months old baby.
Very good. Same age as what Mubin has tried to say that. Okay. Is it a male child or a female child?
It's a female child, sir.
Female child. Okay. So was it a complete cleft or an incomplete cleft?
It's a complete club, sir.
Okay. Was it a right-sided cleft or a left-sided cleft?
Right side, I think, sir.
Right-sided cleft. Which cleft will be more difficult, right side or left side? And whether it is complete lip or incomplete lip, which is more difficult as an anesthesiologist in the management of an airway?
Complete club will be very difficult, sir.
Both sides or one side, left side?
Both sides, sir.
But do you think right side will be more advantageous for you? If it is a complete cleft on the right side and an intact alveolus on the left side, don't you think that you will have more room when you put a scope and lift the tongue to introduce your tube?
Yes.
Correct or wrong?
Yes, sir.
Yes. Supposing it is a wide cleft on the left side, what is the difficulty?
We have there will be no accessibility for laryngoscopy, sir.
What will happen to the laryngoscope?
Especially your Macintosh laryngoscope. What are the parts of the blade of a Macintosh laryngoscope?
Flanks will get stuck, sir.
The flange will get caught in the cleft. Okay.
Okay.
So lifting the tongue maybe. So you are not supposed to lever on the upper jaw or the alveolus in all patients. So but this because of the cleft, you will not have any hole there. So it will be very difficult. There is a possibility the flange will project and go into the cleft and reduce the mouth opening for you for your proper insertion of the endotracheal tube.
Okay.
So now that you did only one case like this, right-sided clip and lip repair.
Sir, 6 months back we have done one case, sir.
No, I'm asking only one case you have done so far, not more than that.
2 cases, sir.
2 cases you have done. Okay. Was there any left-sided cleft patient when you operated?
No, sir. Right,
All
sir.
happen to be right side. So easy to manage. Okay.
Okay, sir.
Right. So how did you anesthetize this child?
Sir, preoperatively we have to ask for any ear infection, sir.
Okay.
And we have
Are you
to
more worried
examine
about
for
ear
any
infection?
anomalies.
Very good. Excellent. All that Mubin described. He said about jaw. He said about the ear. All those problems he described.
Okay, sir.
In the cardiovascular system, what problem you will look for, or what anomaly, or what other congenital defect you will look for? Mubin, you can also answer in between. It doesn't matter that don't be happy that I have switched over to Pavitra and you are relieved. You should also be, because you have prepared, you can answer. Which particular cardiac defect is more common with patients with cleft lip and palate?
Ventricular septum.
Very good, VSD. Okay, right. So that is the most commonest of all the congenital cardiac anomalies, and in patients with cleft lip and palate also, this is the more common anomaly compared to the ASD or other PDA and other things. Okay, right. Okay. So you look for all the congenital anomalies. Was there any congenital associated anomaly in the patient you operated, Pavitra?
No, sir. No.
No, it was a perfectly, otherwise a perfectly
Normal
normal
child.
child, except for the lip defect. Okay, so more than the ear infection, do you look for any other infection? You said it is a case of cleft lip and palate, isn't it? And they operated only on the lip. So when the baby has a palatal defect also, what are all the problems the mother will observe in the rearing up of that baby?
Apnea during feeding, sir.
Will the mother be able to breastfeed the baby?
No, sir. Sucking will not be
Suckling. It is not sucking, it's suckling. It's not
sucking.
possible, probably. Why?
And pressure, there will be a positive pressure inside.
Negative pressure is
Negative.
required for suckling,
Yes,
isn't
sir.
it? So that negative pressure cannot be created by because of the defect in the upper lip. Okay, that is the first problem. Okay, then what? Supposing the baby cannot drink on its own, so they start feeding the baby. When they start feeding the baby, what problem they undergo or experience?
Aspiration.
And
Why
aspiration.
aspiration? What is the mechanism of swallowing? What is the physiology of swallowing? What happens when anybody, whether it's a baby or whether you or me, when whoever tries to swallow, what is the mechanism of swallowing? What are all the changes that happen when you put a liquid or a solid in your mouth and try to push it into your stomach? How does that get propelled into the stomach? Describe the physiology of swallowing.
What happens to the pharyngeal muscles? What happens to the epiglottis? How do you prevent it from entering the other trachea? It should go only into the esophagus. So this is the steps.
Pharyngeal muscles tone will be decreased, sir.
Decreased.
In these patients.
No. Now I'm asking about normal physiology of swallowing.
Okay.
In a patient without any cleft or without any lip defect, when you and me, when we try to swallow, why we are not coughing or choking unless accidentally something goes into your respiratory passage, or nothing comes out through your nose when you drink your daily fluids or eat your food? What is the mechanism? How we are able to easily swallow everything and directly it goes into the esophagus and your stomach? What is the mechanism? That is what I'm asking. See, you put a bolus of food or liquid. Okay, Pratik Shukla, if you are able to answer, please tell me. Yeah, let
Sir,
us be a discussion
trying,
for
sir.
open to all. Yeah.
Yes, sir. Sir, the tongue, as soon as we put a bolus in the oral means cavity, the
Very
tongue
good.
pushes it towards the backside of the oral cavity, means pharyngeal, the laryngeal area, and by that time, sir, epiglottis comes, means epiglottis just means rests upon the laryngeal side, so that it means larynx comes upward and the epiglottis just closes it so that bolus does not go inside the tracheal food, and so the
Goes
then
into
the peristaltic movement of the esophagus then starts, which means lower side becomes relaxed and the upper side start to constrict, and the bolus of the food goes inside the esophagus and it reaches the stomach.
Very good. But what is the role of soft palate here?
So soft palate closes the means or nasal cavity. It means should I say?
See, that is the first step. Before you talk about the epiglottis, whenever you put a bolus of food or a liquid, whatever you want to eat or drink, the tongue rolls back and becomes bulky and pushes the entire food or liquid towards the first hard palate and then slides it towards the soft palate. And immediately once it touches the soft palate, what does it do? It descends down and comes and touches the posterior pharyngeal wall like a curtain, so that whatever you are trying to eat or drink cannot enter the nasopharynx. That is the first step. And when you operate on a child with a cleft palate, it is the duty of the surgeon to nicely repair the cleft and then make the soft palate come and touch the posterior pharyngeal wall, which is called the pushback surgery. They have to raise the flap, repair the cleft, and then push back that flap towards the pharyngeal wall so that velopharyngeal incompetence is first corrected. That is a very, very important step in the correction. So in normal persons, there is no incompetence or a leak between the soft palate and the nasal cavity by the descent of the soft palate with the uvula coming and touching the posterior pharyngeal wall and directing all the food towards the pharynx and not towards the nasopharynx. Oropharynx only it will go. So when the food descends down like that, the soft palate is preventing from going towards the nose. So the only passage it can go down is either to the trachea or to the esophagus. In this situation, what happens? The epiglottis will act as a lid for the larynx and cover the entire vocal cords, so that food will have to slide over the epiglottis, which is attached to the posterior third of the tongue. And then the only opening available for it is the cricopharynx or the opening for the esophagus. So the all will be directed towards that and it will start getting propelled down towards the stomach. So 3 steps. One is roll of the tongue upward, pushing the food towards the soft palate descending and then blocking the entry to the nasopharynx. Then food tries to go down into the pharynx, where epiglottis covers the trachea and directs the entire food or liquid towards the cricopharyngeal opening to enter the esophagus, and then the whole journey starts downwards. Okay. Now imagine a patient who does not have this proper intact hard palate and soft palate. What will happen? The tongue will act like a normal. It will try to roll up and form a bolus which it can push down. But when it pushes up, where will it go? It will have to go through the gap into the nasopharynx. Part of it will go towards the oropharynx and try to go down, isn't it? So if you say roughly as a mathematical example, if you give 10 ml of liquid to a baby with a cleft lip and palate, because it cannot suckle from the mother, 5 ml may come out through the gap through the nostrils, 5 ml may go down, but because epiglottis is there, it will cover the larynx, but at times that cover also may not be adequate enough. So some part may enter the trachea, some part may go to the esophagus. So 3 directions the fluid or the other feeds that you give can travel, one towards the nose, one towards the larynx, one towards the esophagus. So patient may have nasal regurgitation as well as aspiration. So the recurrent aspirations of say water or milk, if the child is not able to swallow properly, what will happen? Which system will get affected frequently? Is it the ear or the lung?
Lungs, sir.
Lungs will get affected. So, and are we interested more in the ear or in the lung? Lungs. So we have to first check for any residual or a persistent LRI in this children. Okay. So that is a more important thing than ear infection. Even a little bit of small discharge from the ear, we are not worried about. Of course, that is also important as a cause of secondary sepsis. But as an anesthesiologist, we are more worried about the normal lung for its function to give anesthesia. Otherwise, it may be an irritable airway, it may cause long laryngospasm, bronchospasm, all these complications are possible. So whenever you examine a child with both cleft lip and palate, your first duty is to rule out associated congenital anomalies. Especially in the heart, you have to see whether there is a associated VSD or not. Then about the other anatomical defects like a small jaw or a low set ear or an alteration in the neck like Down syndrome or Creutzfeldt syndrome, which prevent the proper positioning of the baby. Okay, and then you have to talk about or find out whether the feeding difficulties have caused any aspiration and recurrent lung infections. Okay, after ruling out all these things, then only you can assess the baby and say the lungs are clear. Supposing the mother says 10 days back the child had severe cough, a lot of phlegm, and it was coughing, and I took the baby to the pediatrician, and then I got her treated. Now the pediatrician said the lung is clear, you can go ahead and get the surgery done. How will you know that the lung is now completely cleared of all the infections? The patient is now calm, breathing normally. You auscultate, you don't find any abnormal sounds like bronchi or rales are not there. Air entry is good in all the zones. But you have a suspicion that still the child may not be completely cured because it is a short duration. 1 week only it is treated for LRI. So how to find out whether there is any residual infection is present in the baby or not? During normal auscultation with the baby breathing quietly, everything is fine. Air entry is good, no added sounds. Is there any way to elicit or make an occult infection overt?
Making the baby cry.
Auscultate while the child
Making
is
the
crying.
baby cry.
And
Cry
then
or
listening
cough? Yeah, if it cries also, you will get that thing, but it is not human to make the baby cry by pinching it or anything. But you can make the baby cough. How do you make the 3 months old baby cough? Can you tell the baby, please?
Stimulate the trachea.
Yeah,
Stimulate
how
the
do you?
trachea. Externally, sir.
You stimulate.
Externally,
Which part of trachea you will stimulate? Where do you stimulate? Near the below the cricoid or below the patch below? And what is the name for that procedure or that technique which you carry out to make the children cough out? It is called carinal stimulation, where you can roll your fingers over the trachea in the suprasternal notch. Okay, that is the lowest part of the visible part of the trachea. You cannot do it above, just below the cricoid and all that. Nothing will happen. Whereas if you put your finger in the suprasternal notch and try to roll your finger over the trachea with a little bit of pressure, it will stimulate the carina and the child will immediately cough. And during that time, you can find out any residual infection because that cough will be more phlegmy and it will be more evident for any occult infection. Okay, so don't be carried away by a normal auscultatory finding in a quietly breathing baby with a recent history of LRI. Always perform this test, what is called the carinal stimulation and post-tussive auscultation. Once the baby coughs out, then you auscultate, you will definitely find some few creps in the bases here and there, which is an indication that there is still a residual infection present in the baby, which will tell you that you have to wait. Otherwise, you will land up in a very severe trouble of bronchospasm, excessive secretions, and desaturation. All these problems will happen. Okay, so any children with the history of recent LRI and certified by pediatrician as fit for surgery, don't take their words for granted. You perform your own thorough examination of the baby and do perform this carinal stimulation and post-tussive auscultation, which is a very, very important step in identifying any occult or residual infection in the baby. Okay? Right. So these are the things that you have to look for. Is it an elective surgery or an emergency surgery? Elective surgery. Okay, right.
Yes, sir.
So you have to advise NPO, isn't it? So for a 3 months old baby, what are the guidelines for ordering the NPO status. Pavitra, your audio is not doing good.
4 hours, sir.
Ah. Yeah, breast milk 4 hours, 6 hours or 4 hours? Huh?
4 hours.
Breast milk 4
Form,
hours.
For
formula
feed,
feed
6 hours.
6 hours, breast milk 4
Feed
hours,
6
and
hours.
clear liquids 2
Clear
hours.
fluids
Okay?
2 hours.
Okay, okay, right, very good. So why you can give fluids up to 2 hours? What is the sanctity about it, or what is the guide or recent guidelines say you have to give fluids up to 2 hours? What is the basis behind that?
It can become irritable.
Ah, are you married? Do you have a child, Mubin? You are still an eligible bachelor. Okay, then you won't know how often babies become hungry and how often they require a feed, isn't it? So they usually require feeds every 2 hours. Otherwise, they will become cranky. Okay, so by feeding them just prior 2 hours prior to that, you can appease the child and it will not cry out of hunger. Number one. Any other reason for feeding them? Previously, we were worried about vomiting and aspiration. So we said longer the starvation period, we thought better will be the risk of choice, the aspiration. That was the older concept. But now we want to feed them as frequently as possible up to 2 hours. What is the reason?
Gastric emptying is faster.
Yeah. Gastric motility is much better if you keep the stomach filled with little quantities of fluids rather than completely emptying them. What will happen to the acid secretions if you starve for 6 hours totally? It will be more, and the pH will be much more acidic. Whereas if you feed them, the acid will get diluted and the pH of the stomach also will come down. So these are the 3 advantages you can remember. One is it psychologically appeases the child and makes it less irritable or less cranky and crying. Second is it increases the gastric motility. Third is it decreases or rather increases the pH towards alkalinity by feeding the baby. Okay, so these are the advantages claimed for the feeding up to 2 hours with clear liquids. Okay, and the next common question they ask you is, what are the categories of clear fluids you can give safely? What do you mean by clear fluid, and what fluids you can give?
Fluids are those fluids which are transparent and light can pass through easily.
Very good.
It includes fluid, water, in water, fruit juice without the pulp, and even carbonated drinks are categorized as clear fluids.
Carbonated drinks.
Yeah, that is for eras, not now. When they're not for a child, don't. Usually for eras, that's what they talk about. For a child, when you have clear, you're talking about a 3-month-old baby, isn't it? For the 3-month-old, yeah.
Clear water and
Can you put a little glucose in that and give? Dissolve that
dextrose
and give? Dextrose, glucose powder.
Yes or no?
Not content.
yes,
No.
Without any pulp.
Yeah, that is fruit juice without any pulp, he has said, yes. Okay, so we can give all these guidelines for starvation. Now, Pavitra, can you recollect and tell us how you anesthetize the baby? Baby has been adequately starved. Baby is now quiet. It has come into the OT. How do you anesthetize? How did you anesthetize that child for cleft lip repair? Can you quickly go through the steps and tell us what happened during that experience?
Okay. Sir,
Was there
first we have given all anti-cell injection glycopyrrolate given.
You gave injection
Hello, sir?
glycopyrrolate. Did you give injection glycopyrrolate IM?
IV only.
IV. How did you manage to get an IV line? Was it put in the ward itself and sent to the OT, or did you start the IV in the OT?
In NICU itself, they have, in NICU itself, they have put
NICU.
the line.
3 months baby, why did it go to NICU? So because of the expertise they have for putting line for a small baby, is it?
Yes, sir.
Okay, okay. So
Yes, sir.
it deprived you of the chance of learning how to put an IV line for a small baby. Okay. It should have been actually done by UPGs only. Then only you'll get the experience of cannulating a small kid. Which is quite a challenge. Okay, right. You didn't want to trouble the baby, right? Okay. So the baby came with an IV access. So what drug did you give first?
Sir, injection glycopyrrolate was given,
Did
sir.
you prepare the OT with before the baby was brought
Then,
in, or did you do it in a regular adult OT?
yes, sir.
You didn't make any changes in the OT.
Temperature, what happened to the temperature?
Have you
We
had?
prepared
Have you done any pediatric cases, Mubin?
the OT, sir.
Yes, sir.
So how do you prepare the OT for a small baby? But not forget about this cleft lip and palate. For any small baby, let's say 3 months old baby coming even for a herniatomy or a circumcision, how do you prepare the OT?
As my madam has mentioned, the temperature of the OT will be increased, sir, compared to an adult temperature.
Just tell me exactly how much temperature you will keep. What is the adult temperature which we normally keep in the OT, and what temperature you will keep for a 3 months old baby? You cannot say I will increase, decrease something. You have to, because you have a remote control and you can always increase or decrease the temperature as you wish, isn't it?
Yes.
So normally for adult, what is the advocated OT temperature? Especially orthopedic surgeons are very, very particular about it, because they don't want their sweat to fall in the wound and then contaminate the patient's wound, isn't it? So they want the most coldest theater, 16 to 18 degrees centigrade.
They will keep.
Okay. Whereas we will all be shivering when they will be wearing a lot of overalls and they will not find it difficult. But the anesthetist and the other theater personnel will be the persons who will be shivering in that temperature. Whereas for a pediatric case, what should be the ideal ambient temperature?
28 degrees.
28 to 30 degrees should be the ideal temperature. Especially smaller the baby, more hotter the theater. We don't want them to become hypothermic. Okay. So first, that is the change that you want to incorporate in the OT. Then what are the other preparations you have to make before you bring a pediatric case inside the OT?
For that to check adequate suction.
Very good. Okay. First thing you always check is the suction. Excellent. What type of suction you want?
Controlled.
Controlled. What do you mean by controlled? What is the common suction you use for an adult? The plastic angulated. What is that called?
Suction catheters.
Catheter. It's a plastic rigid angulated connection, no? With a larger
Yankes tube.
Yankes suction. Yankes. Only exam, all these things can be asked. You must be ready. Every day you are using it. It's a Yankes suction. Can you use that Yankes suction for a 3 months old baby?
No, sir.
You cannot. So you have to attach what type of suction catheter you will use for a baby? What is the size of the catheter you have to keep ready for suctioning in case if it is necessary? And what is the color coding for that suction catheter?
Black and white, sir. 8 and 6 French.
6 French. Okay. What is the
6
relationship between French and standard wire gauge or SW gauge?
Standard wire gauge, it's a steel wires that are measured externally, sir.
No. What is the relationship between a French gauge and a standard wire gauge? Supposing you are using a 6 French catheter to apply suction to a small 3 months old baby, what will be the diameter of that 6 French catheter?
So 3 times.
The outer diameter will be 3 times. So divided by 3, it is 2 millimeter roughly. Okay. So French gauge number divided by 3 gives the outer diameter of a standard wire gauge cannula or a catheter or whatever you use. Okay. What are all the common items that are measured in French gauge which we use in the OT? One is your suction catheter.
Sorry, suction
Then you
catheter.
recall
Nasal
any other
gastric tube.
nasogastric tube, NG tube, very good. Then
Foley's catheter.
Foley's catheter. Okay, these are commonly used things. They are all measured, and also for an adult, double lumen tubes are also French gauge only. Whereas your endotracheal tubes are all millimeters in size.
Millimeter.
Okay, so this is all something like a quiz examination. Suddenly trying to find out whether you can recall all these things quickly in the examination. Okay, right. So you want to check the suction. Then what else you want to get ready with?
Next, circuit has to anesthesia workstation has to be checked, sir.
Anesthesia
Then following which, pediatric circle system circuit has to be attached. And next, before for intubation, induction, I have to make sure that I have Jackson's circuit, Miller's and McIntosh adequate size tubes, blades, like for this child 0, 1 and 2, and airways, if possible airway, and for cleft lip, I will also make sure that I have wet gas is ready. And
why wet gas, please?
Since mine is a left-sided
Cleft.
Cleft lip, there is a chance of slippage of the
Laryngoscope blade into
the flange into the cleft lip, and then difficult.
So you want to pack that with a wet gauze. Make a roll and then pack it down, not just pack it like what you do for nasal packing. Okay, you have to make it into a roll, nicely put a micro pore tape around it so that it doesn't slip off, and then you try to pack it. Okay. So would you be able to use the pediatric circle system for this case? Or is there a better circuit than this?
Jackson-Rees can be used as a control.
Jackson-Rees is the ideal, can be. That is the best, easiest and best for pediatric small weight babies. Okay. What are the advantages of Jackson-Rees circuit?
Sir, both assist and the control ventilation can be done immediately, and during manual ventilation we can assess for return of spontaneous breathing. The first class,
What is the full name of this Jackson-Rees circuit? Under what category of Mapleson classification it comes?
Mapleson.
Eh?
Mapleson F.
Mapleson F. What is Mapleson E?
Is
Without a reservoir.
ISTPs, isn't it? So he modified the ISTPs and made it into Mapleson F. So what modification did Jackson-Rees make?
attached a reservoir bag. As a reservoir bag to the
Reservoir bag where?
To the end of the T-piece.
End of the T-piece, or should you call it by some other name? What are the components of T-piece?
Which limb of the T-piece?
Madam?
Which limb?
T-piece is, why it is called T-piece? Because it resembles the alphabet T, isn't it?
Yes, sir.
So what are all the sides of the T-piece? Or which limb, as madam is asking, which limb? How do you describe that T-piece? There is one end going to the patient. There is one end where the exhaled gases are going. There is one point where the fresh gas flow is coming. These are the three things in the T-piece, isn't it?
Yes, sir.
Are you able to understand or imagine what I am saying? You have an inspiratory limb. You have an expiratory limb which is in continuity with that. In between the two, there is an entry for fresh gas flow. These are the three things that make the T, shaped like a T. Okay. So in which part he attached the reservoir bag?
To the expiratory limb.
Expiratory limb of the T-piece, he attached
T-piece.
the reservoir bag. What was the specific description of the reservoir bag attached by Jackson-Ree?
It will have open-ended.
It is an open-ended tail bag, not that plastic white thing which we nowadays find in all the reservoir bags. It is not the way it is to be. Okay, it has to be open-ended, which you can easily pinch and then squeeze if you want to ventilate the patient, or simply assess the function. What is the purpose of this attaching the bag by Jackson-Ree? As you said, you can observe the respiration or you can assess the respiration. Okay. But what is the main advantage of the ISTPs or Jackson-Ree's modification of ISTPs for usage in the pediatric patient? If anybody can answer, Pratik Shukla, you can also answer. Whoever knows the answer, you can unmute and answer. Is there any valve there to be lifted and then to exhale out? In TPs or the modification done by Jackson-Ree, is there any valve?
No, sir, it's not. It's a valveless system.
There is a valve, no valve circuit. So it is a least resistance or difficulty for the patient to breathe. That is the purpose why Sir Philip Ayer constructed this T-piece at all. So Jackson-Ree was his assistant, did not want to spoil that advantage by incorporating a valve. That is why he made a tailless bag to be attached, open tail or valveless tail to be attached. But we modified it because we are so lazy that we cannot all the time be pinching and adjusting the valve. So we have incorporated that. Okay. So that is the first and foremost advantage, because it is a least resistance circuit because of the lack of any valves to be opened, number one. But what are the disadvantages of these ISTPs?
The expired waste gas is let out.
What is the flow rate that you require to ventilate a child or to allow the child to breathe spontaneously with a Jackson-Ree's modification of ISTPs?
For spontaneous, it is around 2 to 3 times.
3 times the what? Minute ventilation. Minute ventilation. Minute ventilation is made up of, how do you calculate minute ventilation?
Tidal volume into respiratory rate.
Tidal volume into respiratory rate. Okay. So if a baby is 4 kgs at 3 months, and it's what will be the tidal volume? Let us say 8 ml per kg. So 4 into 8 will be 32 ml will be the minute ventilation. So if you have to use 3 times, you will have to multiply it by 3. So 96 ml will be the minute ventilation required per minute. So you have to calculate and keep the flow rate accordingly, isn't it? So this high flow rate, does it have any disadvantage?
It can cause barotrauma.
You said it will, wastage will be there, more will leak out, isn't it? If you try to expel it into the atmosphere, you will be causing more pollution, and this high flow rate will cause less expense or more expense?
More expensive.
More expensive. And if you give anesthesia for 3 hours, is this gas humidified or dry gas?
Dry gas.
Dry gas. So all the 3 disadvantages of pumping in dry gas for a long time with a lot of wastage, polluting the theater and costing a lot of money for the hospital to incur. All these things are the disadvantages of the high flow rate required. So the postoperative lung complications because of inhalation of the dry gas is more. Whereas if you use the circle system, what is the advantage?
CO2 removal is possible.
CO2 removal is possible, number one, very good. Then only one advantage?
Wastages of the gas can be reduced.
You are recycling the gases, so no wastage, no economy will be less. And what is the most important advantage about the dry gas and the wet gas?
Humidification.
You are able to humidify the gases. So body does not have to work on humidification. Okay. So you get a better humidified gas, rebreathing occurs with the humidified gas. Okay. So these are all some of the questions that may be suddenly asked. Don't think always the questions will be only about cleft lip and palate. That is the beauty of your practical examination. They can jump from one topic to other topics, circuits, drugs, pharmacology, physiology, everywhere they can jump. A good examiner will be like that only. So you have to be very, very careful. Okay. If you get a routine examiner asking the same questions, you are lucky. You will get through without any problem. But if he is a cranky examiner like me and suddenly wants to jump from one topic to another, you will find it difficult. So, because I presume that all examiners may be cranky like me, I want to train you all to face such situations. Okay? Right. So, Pavitra, can we continue? So, you got the IV line already. How did you anesthetize the baby? I think Pavitra has gone off. Okay, right. Okay, Mumbi, you continue. Now that you are
First
not
we
seen,
have
but you
to induce with
have. How did you induce? Inhalation induction or IV induction? See, you have done the case, so you must be able to recall what you did in the theater, isn't it?
induction.
Huh? No, ma, I think your audio is not good, so we'll not disturb you. Mubin, you continue. We'll finish up. I think you have another session at 7:30. We have to finish. Okay. Go ahead.
Inhalation injection is done in a pediatric patient. Here either step up or step down method with the CO
I think Arun, have you done these cases? Arun, are you there? Anybody who has done some cases like this, I think that will be a better way to go ahead and ask for them.
I've done it twice, sir, but during the DA posting, I was.
Yeah. So you forgot how you did that.
I remember, sir. I still remember it. But,
then you try to recall and tell us how you did it.
Just say in steps what happened, how you brought the child inside, what you did, what IV line, how you did it, what monitors, just in steps.
These are the things they are asking you in the
Normally
exam
do.
also. How you normally anesthetize these steps only they ask you in the exam. So if you have done a case, it should be easy for you to recall and tell and answer the questions, isn't it?
yes, sir. Yes, sir.
Did you go for IV induction or go for inhalation induction?
IV induction, sir.
IV induction. Okay. Is it a 3 months old baby or a much bigger baby you did?
Should be around 3-4.
3-4 months.
Small kid only, sir.
Small baby, infant. Okay, right.
Yes, sir.
So what induction agent did you use?
Midazolam 1 to 1.5 mg, sir. IV followed by fentanyl 2 micrograms per kg. Then propofol as an induction agent 2 mg per kg. We used I think we used atracurium intermediate acting muscle relaxant 0.5 mg per kg, sir. 0.5 mg per kg, 0.5 to 0.6 mg per kg. And after 3 minutes of ventilation, I think either with an airway or we're able to ventilate without an airway, Goodell's airway. Well and truly.
Was it a cleft lip and palate or only a lip? What you did in DA postings?
I think it's a lip, sir. Lip.
I think.
Cleft lip.
So was it in which hospital did you do your DA?
MMC, sir.
MMC. So was it done in MMC or in pediatric?
ICH, sir. ICH.
Okay. So right. Afterwards, after the relaxation is confirmed, what did you do?
And for that, as Mubin said, I think we used gauze to pack the depression so that the scope entry and leverage will be much easier.
So it was also a left-sided cleft, probably.
Yes, sir. Yes, sir.
Okay.
And we used ray tube, which is south pole facing ray tube.
Oral. Okay.
Oral ray.
What
Ring
size?
added element.
What size? What size?
Size, I don't know, so whether it's 4 or 4.5, I don't know.
Okay. Yeah.
But we use the south pole facing
okay.
south pole facing oral ray, sir.
Okay.
Was it a cuff tube? Was it a cuff tube or an uncuffed tube?
I think it's a cuffed, sir. Cuffed, madam. Cuffed.
Cuff tube. Okay.
Cuff tube. Okay.
For 4.5 5 cuff tube is usually we don't use it, but I think we use the cuff tube, sir.
Okay.
Since it's involving the oral surgery, so to be on the safer side to prevent, we use the cuff tube.
Okay. So how did you maintain anesthesia?
Maintenance of anesthesia with oxygen and nitrous and sevoflurane, depending upon the hemodynamics.
Control ventilation.
Controlled ventilation with Jackson Tree circuit.
Jackson Tree circuit. What are the monitors you used?
Standard ASA monitors including pulse oximeter, ECG, NIBP, and we didn't have any ETCO2 over there, sir.
Any other monitor? Pulse oximeter,
Precordial
ETCO2?
stethoscope, sir. Precordial stethoscope with another PG hearing the noise. I was ventilating and the other PG was intermittently helping.
Any other monitor? We already said when the child comes into the theater, we will increase the
body temperature.
But it was not commonly used.
Not there. It was not there.
Okay. So, but ideal to have that also. In this case, supposing you want to use the temperature monitor, how will you use it? Because it is a facial surgery involving the mouth and nose and all these things. So how will you monitor the temperature of the baby? What are the common sites by which you can monitor the temperature?
Rectal, axillary, tympanic membrane. Normally we use a nasal probe.
Nasopharynx.
Nasal probe. Nasopharynx.
So in this case, nasopharynx is ruled out because it is a lip or palate surgery.
Yes.
So where else can you put the temperature probe? Can you put it on the forehead?
Yes, sir.
How can you put it on the forehead? What do you have? What special adapter you have for monitoring the temperature with at the forehead site? What type of probe you have? You have a surface probe where it will be a small flat like a button cell. Okay, that can be pasted onto the forehead or to any part of the body which is covered, not exposed.
and the axilla or the forehead, you'll have to use a surface.
Wherever you can keep the child covered, you can apply that and fix it before you start the anesthesia. Okay. If at all they ask you this question, you can remember this, right? Okay. So all these monitors you used, right? And then the surgery, how did you maintain intraoperative analgesia? Only with the fentanyl what you are given at the beginning, or any other method of analgesia was included?
Before the end of the surgery, we used rectal paracetamol suppository, sir, before the end of the surgery, 10 to 15 minutes.
Okay.
Then,
any blocks were given?
for lip, we can give infraorbital blocks, sir.
Did you give or not?
No, sir, no.
You didn't give. Okay.
No.
Because ICH, you get a lot of cases and they commonly do this blocks also for that. Okay. How to give an infraorbital block? Do you know the theory part of it at least?
Mm.
Especially for a 3 months old baby, if you want to give an infraorbital block, how do you give that?
We have a depression infraorbital notch, which is medial 1/3 and lateral 2/3.
No guesswork. You must
So-
say exactly.
What are the methods? What are the methods of
What are
giving?
the approaches?
Intraoral and I think intraoral and
Extraoral and extraoral. Okay, right. Okay. So was it? It was only a lip surgery. Did the surgeon infiltrate anything in the operative area? Do the surgeons normally infiltrate something there for the lip or palate?
I don't.
Okay, I think this is going to be taking a long time if you ask such questions.
They always infiltrate. They always
Yeah.
infiltrate xylocaine with the adrenaline, especially palate and all that. So it's always infiltration.
Yeah. Okay. Right. So what are the complications that you can anticipate in these cases?
Especially post extubation, the chances of laryngospasm and bronchospasm are high because of the trickling of the bloody secretions if throat is not packed properly. Delayed recovery and pediatric.
I think Pavitra, you don't try, your audio is not good. So you can mute yourself, please. Okay. Right, I think Vasanthi, I will go for the presentation because most of the students don't seem to have done a case, so they are finding it quite tough to answer.